real password problem there. I've never had that before. That was new.
It's unbelievable security here at Rutgers Robert Wood.
Okay, should I share?
Yes.
Yes, I'd like to, Dr. Ritchlin, this is Vivian Sue. I'd like to introduce you. Give me a moment. Can you hear me?
Yeah, of course I can hear you. Yeah, I'm good. Can you hear me?
Yes, we can hear you. It's a pleasure to meet you, Dr. Ritchlin. I'm just gonna say a minute of introduction and then I'll let you take over. So we're very
That's fine.
privileged to hear a nice discussion from Dr. Ritchlin. He's Division Chief, Allergy, Immunology, and Rheumatology at the University of Rochester. And he's basically a New York person all the way. He went to medical school at Albany Medical College and then did his residency training at Mount Sinai and fellowship at NYU and graduated in 1989. Subsequently received an MPH at University of Rochester in 2008. He has a basic interest in research on the understanding of the mechanisms that underlie pathologic bone resorption and new bone formation in psoriatic and rheumatoid arthritis. And he has also done a lot of research on the effects of anti-TNF agents on dendritic cell differentiation in RA and psoriatic patients. He's the director of the Clinical Immunology Research Unit, where he is the principal investigator of many clinical trials testing the efficacy of anti-TNF agents and other biologic molecules in the treatment of psoriatic and rheumatoid arthritis, as well as ankylosing spondylitis. He's written many chapters on the pathogenesis of psoriatic arthritis and reviews, including one that I found in the New England Journal of Medicine in 2017. So we are very privileged to hear him talk about psoriatic arthritis, overcoming barriers to improve patient outcomes. Thank you.
Thank you, Vivian, for a lovely introduction. Let me just share my screen here. I think you need to get off the. Do you give me control, Vivian? I'm not having it.
I have no control.
Rachel, can you give Dr. Ritchlin? There you go. You should have it now.
Don't have it. Don't have it. I don't know why, but I don't.
You're listed as the co-host, so you should be able to share.
I'm looking at you and it's not allowing me to share. It's not showing my screen. Let's see. No. Not there.
While we're ironing this out, do you want to, maybe you can email it over to me? Oh, actually, I think I have it. I can.
Yeah, it's definitely not letting me share.
Try now.
Nope, it's just showing you and not allowing me to get into my files. Again, I've never seen this before either. Hold on, once allow Rutgers to do that. No, it's not allowing me to share. Not showing any of my stuff.
Okay.
Do you have the presentation? I mean, I can.
Yeah.
It's a big presentation. Okay, so
Yeah.
we're going to have you control the slides, I think.
There you go. We'll do that.
Okay, we will get started here. So, yeah, this has been an incredible time over the last several years for our understanding of the key mechanisms that underlie psoriatic arthritis and rheumatoid arthritis, for that matter. And so, what I'd like to do today, next slide. These are my disclosures. Next. So we have a major challenge in front of us, as you all well know, and that is to achieve therapeutic outcomes in psoriatic and RA arthritis that are a similar magnitude to those observed with the newer biologic agents in psoriasis. So I have the pleasure, and some of you may as well, of working in a combined clinic with dermatology. And when it comes to psoriasis, they have a lilt in their step because their treatments are so effective now for the treatment of psoriasis. And we long to have those kinds of outcomes. And I'm going to talk about that this morning. Next slide. So here we see the problem that we face in rheumatology. So what you're looking here are the various targets, TNF, IL-17, 12, 23, and 23, with representative agents. And you can see here, I'm looking at deeper responses, the ACR70 with these agents moving really from Phil Meese's study in 2001 until now. And you can see the ACR70 responses, and you can compare that to the deeper responses in psoriasis, which is the PASI 90. And we can see that there is a very large gap in terms of the kinds of outcomes that we really want to achieve in the arthritis. Next slide. So the question is why? Why is it so difficult to achieve these outcomes in PSA and to a similar degree RA? And part of the answer is shown here, and that is there's a number of tissues involved besides the skin in psoriatic arthritis. So you see the skin, the joints, the entheses. We also know the bone marrow has a contribution as well, and the gut. In the skin, the joints, and the entheses, we know that the key pathways are IL-23 and IL-27, as well as TNF. But there's differential impact in these tissues according to the pathways that are key to driving the pathology. So in the skin, work from Jim Kruger's lab at Rockefeller and Belasco showed that the key transcriptomic pathways that are driving psoriasis lie in the IL-23, IL-17 area. Whereas in the joints, although IL-23 and 17 are certainly important, it seems that at least from a transcriptomic perspective, it's a TNF signature that predominates. And the Th1, which of course is T-bet gamma interferon, is pretty equal between the skin and the joints. So here's one area where we're seeing a lot of heterogeneity, and it brings forth the question as to whether or not a single agent is going to be able to cover this massive immune landscape. My own view on that is that it's not going to, and we'll talk about that later. Next slide. So the other complicating area is one you all know well, and that is the domains. So in psoriatic arthritis, we have all of these domains that can be present. And usually, in work from Alexis OD, a patient has at least 2 or 3 domains of involvement. So you once again have to think about how do we cover all of these with our therapeutic approach in a way that will be efficacious from a comprehensive perspective. Next slide. The other component here, of course, are the comorbidities, and these are very common and problematic in our patients with psoriatic disease. It's psoriasis, but it's also psoriatic arthritis. And I'm going to speak a little bit later about obesity, which is such a huge challenge and so responsible for the lack of good response to many of our biologic and conventional DMARDs. Next slide, please. So we know that we have a large treatment toolbox in psoriatic arthritis. We have conventional DMARDs on the left, biologic agents, lower left-hand side, newer therapies, some of which are not so new anymore. This is an older slide, but right now fairly timely. And then a number of adjunct therapies that you know well, and we carry out in our offices to a varying degree. But despite this huge treatment toolbox, our outcomes in psoriatic arthritis have not improved dramatically since Phil Meese's first phase 2 trial in 2001 with etanercept. And so is it because our outcome measures, the ACR 20, 50, 70, have a ceiling effect, or is it that we're just not targeting the right pathways, or do we need to use other approaches? Next slide. So in this presentation, I want to talk about potential solutions to this problem. One is to uncover a new pathway or cell subset. The second is lifestyle modification. An area that we're about to embark on is earlier intervention in treating patients with psoriasis before they develop arthritis. And then a last topic, which is something we're really excited about and moving forward on, is combination biologics in PSA. Next slide. So here I want to talk about these solutions. I'm going to concentrate first on CD8 positive T resident memory cells. I'm not going to talk about tissue resident osteoclasts at this point in time, although it's something our lab is very working hard on. Weight loss and intermittent fasting, and then the preclinical intervention. And then lastly, we're in an era now where we're seeing head-to-head trials in psoriatic arthritis, something we've never seen before. And I just want to go over a few of those before I end and talk about combination biologics. Next. So let's have a little bit of discussion on CD8 resident memory cells. Next. So this was a key study that came out several years ago. And in this study by Bruce Kirkham's lab in London, they asked the question, what are the cells that are predominating in the synovial fluid in PSA? And what you can see here is that CD4 negative or CD8 positive cells are sequestered in the synovial fluid of PSA patients, but not in the peripheral blood. Moreover, if you look at the cell population in patients with RA, it's neither present in the peripheral blood or in the synovial fluid. Look in the upper right-hand corner, you can see that CD8 or CD4 negative cells correlate with power Doppler ultrasound findings in PSA, where CD4 do not correlate very well. And if you look to see other key outcome measures such as CRP, SAT rating DAS28, once again, it's the CD8 or CD4 negative cells that correlate with these important measures and not CD4 cells. So this always was a great interest to me, this study. I trained in a lab of Bob Winchester at NYU HJD. And of course, he is an MHC maven, and he would always drill into us as fellows that, listen, psoriasis and psoriatic arthritis are class 1 MHC diseases. They're driven by CD8 cells. And it's now becoming clear, as you'll see more in a moment, that that is certainly the case. Next slide. So I want to talk about T resident memory cells for a moment. This is an area that's really come on to the front stage in our diseases. So these are T lymphocytes that express CD69, and a subset of them express CD103. They're in both the CD4 and CD8 subsets, although I'm going to focus on CD8 today. They provide rapid on-site response and reactivation. The highest number are at sites of primary activation. So in other words, if you have some kind of infection in your skin and there's a site of entry, that's where the highest number of these cells will be present, but they'll also then fan out and circulate over the entire skin, but their density in the other areas will be less. They're long-lived, and it has been thought that they do not recirculate. That is inaccurate based on very recent data that I'll discuss in a moment. They're antigen-specific. They're in the skin. They respond to the pathogens shown here, whereas there are different pathogens, as you might expect, that they would respond to in the gut and in the lung. And as you will see, they are also in the joint. If you want to read a great review on this, Clark's review in Science Translational Medicine, although dated, is really excellent. Next slide. So these cells can be either homeostatic, as I just described, or they can be inflammatory. And they've been shown to partake and be key effectors in allergic diseases, injury, and in autoantigen exposure. And most importantly, in psoriasis and PSA, for the sake of our presentation today. Next slide. So here is the thinking, and don't get freaked out by this slide. I'm going to make it very simple. So for those of you that are not immunology mavens, well, some of you I'm sure are. So there are 3 key subsets in the memory cell population. The first is in orange, and this is the central memory subset, which circulates in the peripheral blood and then enters through high endothelial venules into the secondary lymph nodes. Organs or the lymph nodes is shown here. Of course, they're exposed to antigens presented by dendritic cells. The effector memory cells shown in blue are in the circulation. They do enter into the lymph nodes, but not through the high endothelial venules. But they, unlike the central memory cells, can circulate to the tissues where they're present and can interact with other cells present there. The focus of my talk now, we need to go back there, I'm not finished, thanks, is on the central memory cell, effector memory, resident memory cells, excuse me, I screwed up there. And these are the cells I just talked about, and they're present in the peripheral tissues. And they're there as sentinels to react to pathogens as I described, but also can be important in autoimmune and immune inflammatory diseases. And in this model, which is an inside-out model, which we all learned in medical school, the antigens are presented in the lymph node by dendritic cells to T cells and B cells, which then circulate from the lymph node to the peripheral tissues. And this is where this inside-out migration term comes from. I'm going to tell you that it's probably not accurate. Next slide. So coming back to what are the clues that T-resident memory cells are important in psoriasis? Well, one, we know that psoriatic lesions tend to occur and recur in the same locations, and these are where the highest density of these cells are. We also know that in PSA that oftentimes joints flare in the same joints. So I think this is an analogous situation. We know that E-selectin blockade was ineffective in psoriasis, and of course, E-selectin is present on circulating cells. Perhaps the most convincing data came from an experiment that was from Nestle's lab in London, where they took non-lesional psoriatic skin grafts, transplanted them to immunodeficient mice, who then went on to develop psoriasis. And when they examined the psoriatic lesions in these mice, they were filled with these T-resident memory cells that were driving the response from the human skin. And again, these were non-lesional. So even in those skin from a psoriasis patient where there's not a psoriatic plaque, these T cells are there. We also know from a variety of studies that gene profiles of inactive and non-lesional skin show abnormal gene activation. Again, work from Kruger's lab. And moreover, when you look in these lesions that are not psoriasiform, but were psoriasiform, you have CD4 cells that are expressing interleukin 22, which we know is very important at driving keratinocyte proliferation, and CD8 cells, the focus of my interest, are expressing IL-17, and they're in this previously lesional skin. Next slide. Same group, more recent paper. Once again, IL-17 expressing CD8 T cells seem to be congregating in the synovial fluid in PSA, but not RA. They're also, interestingly, in the synovial fluid of spondyloarthritis patients. When you look in the lower left-hand corner, so we're looking at those cells that are CD8 or CD4, and we're looking at the markers for T-resident memory, and look, they're there. They're there in both of the CD8 and the CD4. If you glance over to the lower right-hand corner, you can see the CD8 cells that are also expressing IL-17, and look at the different cytokines they're also expressing: gamma interferon, TNF-alpha, GM-CSF, and IL-21. So these cells, sequestered in the synovial fluid, are polyfunctional. They're highly activated, producing not only IL-17, but a host of other cytokines we know are of key importance in driving the synovial and enthesial reactions that are so characteristic of PSA. Next slide. In another very important study from Oxford last year, from a very fine lab, they took synovial fluid and blood from patients with psoriatic arthritis in the upper left-hand corner. They combined them, this is a single patient, and performed mass cytometry or CyTOF. And they were able to demonstrate a variety of different cell populations in the blood and synovium, as you can see here, including memory CD4, memory CD8, CD8s, macrophages, and other populations. When they went and divided this up into the synovial fluid of the patient versus the peripheral blood, what they found was that there was a congregation, again, of these memory CD8 cells that were highest in the synovial fluid when compared to the peripheral blood. They then went on and did single-cell RNA-seq in the upper right-hand corner. And here, this is on the synovial fluid only. You can see that there are a number of CD8 populations. And most relevant to this discussion are the ZNF cells shown there. This is another marker of T-resident memory. And they found that this T-resident memory population was the most elevated in the synovial fluid compared to the blood. You go down and look below, they then did a clonotype, so they sequenced the alpha beta receptors of these cells. Remember, I said that these cells are typical alpha beta receptor expressing T cells, not gamma delta or other innate kind of T cells. And what they showed were that there were clonotypes. So these were restricted T cell receptor repertoires, and you can see 3 different clonotypes shown below. The triangles are the CD4 cells, the circles are CD8 cells, the red are those that are statistically increased. And you can see in these 3 different clonotypes that it's the CD8 cells that are most notably increased in the synovial fluid. And interestingly, one of these clonotypes is one that's been previously described to be expanded in psoriasis skin. So now the question that I've been dealing with is whether or not there are clonotypes that arise in psoriasis skin and then go on to involve the joint. Next slide. So recent papers, two papers that came out, one from Fonseca in Nature and on Immunology, and a paper just came out this week in the journal Nature from David Musapus's lab in Minnesota, really tell us that these T-resident memory cells are not necessarily parked in the peripheral tissues. So before I told you about inside-out migration, I'm going to tell you now that there's actually outside-in migration. So once again, if you have these T-resident memory cells in the tissue shown in blue down at the bottom, it turns out that they can actually be reprogrammed. And whether they're reprogrammed into effector memory cells is not clear, but they can then leave the peripheral tissue, go to the bloodstream, enter through the high endothelial venules into the lymph nodes, and then program other T cells or themselves be reprogrammed to then return to the tissue and carry out effector functions. This is very exciting for us because now we might be able to capture these cells in the peripheral blood. And my own hypothesis is that these T-resident memory cells are arising in the psoriatic plaque and then circulating to the entheses and to the joints and carrying out the inflammatory process we know as psoriatic enthesitis and synovitis. And we're in the process of trying to prove that hypothesis by obtaining tissue from the skin and the joints from the same patients with PSA. So this is the outside-in migration. So we've done staining. You're fine. You can go to the next slide, David. So we've done staining of synovial tissue from a patient with psoriatic arthritis, kindly provided to us by Lee Eater in Toronto, although we do our own biopsies, but this was a great tissue. And you can see here staining for CD8 in green, 103 in white, 69 in red. Remember, those are markers of this population. You can see that there are CD8 cells in the synovial tissue that are expressing both 103 and CD69. And you can see the overlap of, in the right-hand corner, of a higher power magnification of the combination of CD8 and CD69. So these cells are in the synovial tissue and not just the synovial fluid, which was really very exciting to us. Next slide. So, a lot of work is going to go forward in this, trying to uncover the role of the T-resident memory cells, not only, by the way, in PSA, but also in RA. And there's some very compelling data from Harvard that they're there as well. Is there any way, David, you can get this slide to be, this is a slide that has video, and you have to click on the bottom to get the video started. I don't know, I don't know what you're in, but if you, on the bottom, there should be an arrow.
Yeah, because of the size, you sent me the PDF and not the actual PowerPoint.
Oh, you have the PDF. Oh, I'm sorry. Okay. Well, just imagine this for a minute then. So we've been studying the concept that perhaps the flare in rheumatoid arthritis and psoriatic arthritis might be related to lymphatic flow. And we've been studying this for 8 years. We're now in our third R01, just got renewed, trying to sort this out in mice, and now we've gone to humans. So basically, the story in mice is if you take a TNF transgenic mouse, it spontaneously develops arthritis at about 6 to 8 weeks in the females. That prior to the onset of arthritis, their lymph node draining the affected joint expands dramatically. And then prior to the onset of the sign of synovial swelling, the lymph node collapses dramatically. And right following that, you have this development of synovitis and erosive arthritis. So we've been studying this for a very long time and found out that it wasn't anything to do with the lymph nodes so much as, in other words, in collapsed and expanded lymph nodes, the cell populations were the same. There wasn't anything different that we could determine. What we did find, though, was once that lymph node collapses, that the lymphatic vessel distal to that lymph node no longer contracts. And in each of us, we have lymphatic vessels that contract at a rate of about 1 per minute, excuse me, to return lymphatic fluid from the tissues to the thoracic duct. So we decided we needed to take our work from mice to humans, and we obtained an IND investigative drug initiative for indocyanine green, which we inject into the web spaces of the patient. This is a control. And then we follow the time it takes the indocyanine green picked up by the lymphatic vessels to leave the tissues, and then we follow them up into the draining lymph nodes. And what you would normally see here is you would see us injecting this, it looks like fluorescence on the camera, into the web spaces and seeing it moving up very quickly in the vessels, because we have a speed up camera, because obviously it's a 1 contraction per minute would be pretty slow moving. Okay, so we then took this and looked in patients with RA and controls. Next slide, please. So this is published in A&R in September. Richard Bell is the first author. He's an incredible PhD student and now is working with Lionel of Ashkiff at Hospital for Special Surgery as a postdoc. So basically what we did is we injected control on the top, RA on the bottom, with the indocyanine green, and then we measure the egress from the tissue a week later. And you can see in the above panels at the control patient, you have very nice clearance at a week. And you can see in RA, in this particular individual, that's not the case. And if you look over to the right, you can see on the graphs that we have nice is not a great word. We have good clearance, timely clearance and controls, and that's not seen in most of the RA patients. So we think this is really interesting, and we now are going forward to study various populations of RA patients and PSA with early disease, late disease, mid disease, before and after therapy, in a variety of settings to try and better understand and elucidate what role the clearance of the joints in terms of the lymphatic fluid is. We do know that we've looked at this in mice, that the lymphatic fluid is full of inflammatory cells in the arthritic mouse model. And most importantly, there are CD11B cells, which we know bind to the lymphatic endothelium and also damage it. We have electron micrographs which show severe damage to the endothelial vessels leaving the lymph node that's coming out of the affected joint. And we have other data suggesting that there's a smooth muscle deficit, which is why we lose the contractions. So there's a lot of work going on that right now in the lab from Mark Kenny, and I think we've got some important insights we'll be talking about at that coming ACR meeting. Next slide. Now listen, I would be remiss if I didn't go over this incredibly important study from Dana Orange at Hospital for Special Surgery in Rockefeller, where they did an amazing approach where they were able to have patients get their blood at home when they had RA but were not flaring in green. But when they had a flare, they were drawing their blood right through that and also through to the resolution of the flare. And as you recall, what they were able to show was that, shown in purple, that there was this release of B lymphocytes prior to the onset of the flare, and as the flare started to progress, they moved into the release of these mesenchymal cells. And they're shown here on the right are the differentially expressed genes of both the B cells and the mesenchymal cells. Pretty amazing way of looking at this and very exciting. So obviously this may be another mechanism of flare, and it could be that there are multiple different variables that are going into flare that not only include the lymphatic contraction loss, which I just showed you, but also the activation of cell subsets that are resulting in local joint inflammation. What's causing the release of these B cells? We don't know right now. It's obviously a very active area of investigation. Next slide. So now I'm going to talk about an area that's particularly close to my heart, and that is the transitions. So how can we identify preclinical high-risk patients who have psoriasis but high risk for PSA to alter disease course? Next. This is a well-quoted paper from Will Tiller from Bath, England, works with Neil McHugh, and he looked at the UK Clinical Practice Research Data Link and showed, and what he tried to determine was if you look at time 0, that's when the patients develop PSA, and something you already know well, and that is that the majority of patients with PSA have PS long before, and there is certainly a peak at the time. In some patients, they have the concomitant onset of both skin and joint disease, but most patients, it's about 6 to 8 year time lag before they develop arthritis in those patients with psoriasis. Next. And there is a transition. So about 3% of patients in the United States, 2 to 3% develop psoriasis, and most have psoriasis prior to PSA, as we just saw. About 25 to 30% develop PSA, and we know that PSA risk alleles, microbiomal variables, as well as the activation of a number of key effector cells, osteoclast precursors, Th17, CD817, and other effector cells result in the development of PSA. And work from Leahy Eder in Toronto with the IPART database showed that about 3% of patients with psoriasis a year in our longitudinal cohort develop PSA. So obviously this number is way too small to do an interventional trial. You'd have to have a huge number of patients. So we've been working very hard, myself, Jose Scher, Alexis Ogdi, and Joe Marola, to try and define an enriched population, which is more likely to develop PSA that we can try and intervene in. Next slide. So this just shows you those risk factors you know very well. We reviewed this in Nature Reviews a couple of years ago, put all the background literature in there. And of course, these include scalp psoriasis, nail disease, inverse psoriasis, the presence of disease in first-degree relatives, the severity of psoriasis, obesity in a dose-related manner, as well as a number of other biomarkers that have been proposed, but not definitively proven. Where we have found the most gold in this is down below in the imaging area. So we have performed in a cohort that we included in a study that we're submitting the paper now, presented at the ACR, where patients that have psoriasis, and we screen them for having more than 5% BSA, no musculoskeletal symptoms, and they had to have key findings on ultrasound in their entheses or joints. And we set a baseline score for that. And we found that the patients that had the ultrasound, it was the most significant predictor of the development of psoriatic arthritis. So we followed these patients longitudinally over 5 years. So with that in mind, next slide. We're about to start an interventional clinical trial, I believe in July. And the idea here is we're going to have 3 groups of patients. These are going to be patients with psoriasis, no musculoskeletal signs or symptoms, and they are going to have an ultrasound of joints and entheses. We're going to use a PSA SON outcome measure, and they need to have a threshold measure to get into the study. Group 1 will receive an IL-23 inhibitor from baseline. Group 2 will be delayed in that receipt of that until 6 months later, and will receive placebo. And then we will have a standard of care group, and there are many of these patients, I didn't really understand this, they don't want to take conventional DMARDs, don't want to take any biologics. They will have a phototherapy over, don't want methotrexate either. And most of these will be coming from Newfoundland, Canada. And we're going to have 2 co-primary outcome measures. The first will be the change in ultrasound score at 6 months and a year, and the second will be the development of PSA at 4 years. So we're hoping, obviously, during this longitudinal study to collect a variety of biomarkers, both imaging, cellular, sera, and transcriptomic, which will provide insights moving forward over time as to what are the key biomarkers that are unfolding over the course from psoriasis to PSA. We spent 3 years planning this study. We've got sample calculations I can share with people if you want to see them that we've gone back and forth with, and we're really excited to get this study started. So I believe it's going to be in July. You know, this is investigator initiated. Jose and I headed this up, and the amount of work involved in developing the protocols and getting through all the underlying paraphernalia was really quite incredible, I gotta tell you. Anyway, so we're going to move forward with this. It's great. Next slide. So I want to speak briefly about obesity. As I mentioned, it's a major barrier for me in my clinic and in my combination clinic. And I struggle trying to be able to convincingly have my patients lose weight so we can improve their responses. Next slide. You've seen this paper, it's published. I'm sorry, I should change the reference. It's published in J Room, And then the follow-up a follow-up paper was 1 year, and then there's 2-year data now from the same study. This is from Klingberg in Sweden. She used weight loss to see if it would improve PSA disease activity. Pretty incredible study, 41 patients with a very high BMI. She put them on this very low energy diet, which was 640 kilocalories per day for 12 to 16 weeks. And then that was followed with calorie restriction, but not so severe, and counseling over time. And the PSA treatment remained stable. Amazing median weight loss, 18.7 kgs, and median BMI, you can see. And she was able to double the MDA just about, which is a pretty impressive measure. And you can see here the variables they looked at. Admittedly, this patient population was not very active. Remember, they're still on treatment, although not responding at the time when they were enrolled in the study. But nonetheless, even with fairly low disease activity, they had very significant changes over this period of time. And I can tell you that I think the next slide shows you. Yeah, so this is at 1 year, and results are similar at 2 years. And what's amazing is only 2 patients dropped out. They were able to maintain their weight loss, and they still showed very significant improvement from baseline in all of these measures. So I'm convinced there's other data too that weight loss is an important adjunctive therapy for our patients that suffer from obesity. Next slide. So there's been a lot of talk about intermittent fasting, and this is the person that really, I think, has driven it into the popular literature and the scientific literature. This is Walter Longo from northern Italy, came to Texas to be a rock and roll guitarist. I guess there's a school down there for that. I wasn't aware of that. Anyway, while engaged in learning the chords, and he got interested in rheumatology. I don't know where that came from, but he then went and got his PhD and has a very large lab at USC. And his interest is in rheumatology and, quite frankly, dietary manipulations to improve longevity and slow aging and help to decrease disease. A very fine scientist. He's got a lot of work in animal models and has moved into humans. And as you all know, if you want a mouse to live a longer life, you just calorie restrict them. And it looks to be the same thing with humans. If you haven't taken a look at this book, I strongly suggest you do. It's quite entertaining and very scientific and well done. Next slide. So just before Christmas, this article came out. It seemed like cruel punishment 3 days before the Christmas festivities. This was on intermittent fasting clinical practice in the NEJM by DeCabo. And he talks about how intermittent fasting can be taught to a variety of different people by different teachers, if you will, on the top. And then he describes various sample prescriptions one can use, starting with decreasing the feeding period from 10 to 6 hours, and then having days during the week where you have caloric restriction. The rationale behind this intermittent fasting is shown in the next slide. Great paper, by the way, if you're interested in this topic. So negative energy balance is shown in the top, results in decreasing glucose and the use of alternative metabolic fuels such as fatty acids and ketone bodies. On the other side, the negative energy balance also alters sensory sympathetic innervation, resulting in the increased release of neuroendocrine hormone effectors such as ghrelin, FGF21, and GDF15. And then you have both of these factors converge to result in an integrated immunometabolic response with decreased glycolysis and increased fatty acid oxidation. And you can see that this affects 4 very important axes. One that's very central to us, of course, is the immune response, and results in homeostasis and longevity. And the basic concept here is pretty simple, and that is, if you're not eating meals 3 times a day, then your system is not gauged toward digestion, that it's gauged toward other processes such as autophagy, such as generating new stem cells and doing the housekeeping activities that are being drawn away by the digestive process. And again, there's really good data for this in animals and somewhat in humans. So what's the data that it affects the immune response? Next slide. This is a really interesting study. So this is in mice. but it has relevance to humans. So as you can see, they took these mice, they fed them for a period of time, they removed the food and then fed them again, and then removed the food for a longer period of time, and they drew blood at 2 time points. And the study here was designed to address the question as to whether or not calorie restriction or food restriction leads to an alteration in immune profiles. So then once they carried out these studies in the mice, they then used flow cytometry or mass cytometry, as I showed you before in the other study above Pankova, and they looked to see what was a change in immune cell subsets. What was pretty surprising is, even though it was a brief period of fasting, on the left lower corner, you can see that there's a significant decline in circulating monocytes, and also in a more focused inflammatory monocyte population, a CD16-14, you see that they had a very significant drop. Whereas other cells shown here as neutrophils, but also lymphocytes, B and T lymphocytes, did not change their numbers following fasting. Next slide. They also looked in a number of important parameters in the blood. I'm going to focus for this only on the wild type and not the P-para knockouts. And you can see here that there is a significant decline in TNF alpha, CCL2, as well as other metabolic factors, including insulin, C-peptide, etc. And down below, you're seeing that ghrelin, resistin, glucagon, and other are increasing, whereas other cytokines are staying the same or decreasing. They found that the short-term fasting resulted in a decline in monocyte metabolic activation with impaired egress from the bone marrow, the suppression of CCL2, very dramatic suppression actually. Nonetheless, there was no compromise in the emergency monocyte mobilization during infection or inflammation in these mice, so they were able to respond to danger signals. They also showed in the study that there was decreased inflammation in the allergic encephalitis model with this approach. There's a lot more about this coming out now. I don't have time to cover it all, but if you're interested, you can really start with that immunity paper and take a look at Dr. Longo's very entertaining and scientific book. Next slide. So I'm going to conclude here talking about therapeutic advances and mainly on the emergence of head-to-head trials. Next. So this is the Spirit head-to-head 24-week trial. It's been out for a while, head-to-head ICSI versus adalimumab. As you can see in this study, that the ACR 20, 50, 70 down below are pretty much identical for both ICSI and adalimumab. We see that the PASI 100 was significantly better with ICSI. And then if you combine the primary endpoints of ACR 50 and PASI 100 shown below, on the left-hand side, lower left-hand corner, that ICSI has an advantage for treating both the skin and joints. Next slide. Here you see, again, this is a study which is head-to-head. This is UPA versus placebo and adalimumab as a comparator. Adalimumab is in the reddish purple. The gray is placebo, light green 15, dark green 30 milligrams of UPA. Again, you're seeing that these have comparable responses to adalimumab, not significantly greater, but certainly numerically superior, more with the 30 than the 15. Also, other important parameters, including resolution of enthesitis and dactylitis, and then surprisingly, very robust PASI responses with an oral agent. And here we see that the 15 was as equivalent to the 30 for the PASI 75, not so much the 90, but certainly numerically similar, if not better, from what we see here to adalimumab. So here's an example of where an oral JAK inhibitor may have a very effective role in psoriatic arthritis. It's important for me to tell you that the PDUFA date for UPA in psoriatic arthritis, meaning when it was to be ruled on by the FDA, was March 26th, and the FDA did not rule on that. They asked AbbVie for additional data, and I suspect that that will be, we'll hear more about this in June in terms of its approval. Next slide. This just shows you that the MDA change in HAC-DI radiographic changes were comparable between UPA and adalimumab. In the lower right-hand corner is the adverse event table, and as you might expect, there were significantly more adverse events in UPA 30 than 15, which is why I think it's very unlikely that that dose will be approved, and as it was not in RA. So we'll have to see how this unfolds over the next couple of months. Next slide. You know the EXCEED trial. This also came out recently. Adalimumab versus secukinumab. Longer trial, 52 weeks. They use multiple imputation. And when they use that outcome statistical approach, they did not see a significant difference between secukinumab and adalimumab on the ACR 20 response. They did have more dropouts in the adalimumab group, which somewhat affected their statistical analysis. Nonetheless, it shows you that 17 blockade appears to be as effective as TNF blockade with adalimumab. Next slide. Similar to the, no, that's, I gotta go to the one after that. Keep going forward. One back. One back. I know this is hard. It's fine, just stay there. It's okay. And then one more. And this is just showing you, similar to the Spirit head-to-head trial, that the combination of the ACR 50 and PASI 100 was better, next slide, with the secukinumab than it was with adalimumab. It's shown right here. Similar effect, actually adverse events were similar between the two agents, which was somewhat surprising to me. I thought secukinumab would take the edge, but they didn't. Obviously, in a small trial like this, you can't make a lot of conclusions about adverse events. Next. Very briefly, you know about the Discover 1 and 2 trials that led to the approval of guselkumab. What they did in this trial is, Roman, interesting to know, is they took a subset of patients with axial disease as determined by the site PI, and they had to have certain imaging abnormalities historically, either an abnormal X-ray or MRI, which was locally read for Discover 1, or a current abnormal SI X-ray locally read for Discover 2. They looked at these patients in terms of the spinal outcome measures that they selected, and they show here, compared to placebo in gray, both of the guselkumab Q4, Q8 week dosing were superior, as also with the BASDI 50. Next. They also looked at ASDAS and ASDAS-CRP, again showing significant improvement. The problem with this study, and we've talked about it with colleagues from axial and peripheral interests around the globe, is that it's known and been shown that when you're measuring axial disease in a peripheral arthritis population, of which this was, that the axial measures you get may not be valid. They may not be accurate. So it's also the imaging being locally read. We know that this is fraught with problems. Over many years now, we've learned that lesson. So basically what needs to be done in order to show that IL-23 blockade is effective in axial PSA, while we know it's not effective in axial SPA from a number of studies, next slide, is to carry out a study like Maximize. So this is the Maximize study with secukinumab in patients with axial PSA. They had baseline MRIs done and centrally read, and we know that the patients that received secukinumab had better axial responses than those that received placebo. We also know from these data that the MRI or Berlin MRI scores were significantly improved in the patients that received the 17 blockade in the two blue colors compared to placebo. Interestingly enough, though, that the response to the MRI did not necessarily correlate with the clinical response of the ASAS-40 at week 12. In any event, I know that Janssen's going to move forward to carry out a trial like this to really determine whether or not 23 blockade is effective in axial PSA. And that would be really interesting because it would suggest that the mechanisms of axial SPA are different than the mechanisms in axial PSA, at least in regards to 23 events. Next slide. I'm going to close on combination therapy very briefly. Next slide. So you know this trial, the ABT-122 in PSA. AbbVie took and combined anti-TNF and IL-17 antibody in a bitypical structure. They then treated patients with PSA and compared this to, once again, adalimumab, shown in this typical blue, red, purple color. Placebo in gray, 2 doses of ABT-122 in light green and dark green. And the primary endpoint, as you might expect, unfortunately for this study, was the ACR 20, and you saw similar responses between the 2 doses of ABT-122 and adalimumab, greater than placebo, however. When they looked at the ACR 50 though and the ACR 70, you can see that the higher dose of ABT 122 did very well, better than adalimumab, significantly so. And but you look over at the PASI 75, the changes were similar to adalimumab for the skin, and the enthesitis index shown over on the bottom were similar. I think the major outcome from this study, which I don't think was appreciated enough, was that the adverse event profiles were no different between adalimumab and the 2 doses of the ABT 122, which is really very important because, as you know, 15 or so years ago, the combination of TNF inhibition with IL-1 receptor antagonist and RA proved to be an unmitigated disaster. A combination that worked in a mouse model resulted in decreased response compared to the TNF agent alone, and the patients suffered a very high rate of infections, leading them to stop the trial. So the question now becomes, well, if we have newer agents now that may be less suppressive of certain cytokines, might this be an approach that we can use in PSA? Next slide. There is a trial that's been completed. We don't have the results yet, using combination biologics in another very refractory disease, ulcerative colitis. This is combining guselkumab and golimumab, and you can see here the protocol where you have the combination versus the monotherapy alone. As I said, this study is completed enrolling. We're looking for the results in the fall, and we're obviously very eager to see the safety profile of this approach of combining these 2 molecules. Next slide. So this is coming out, this paper soon, that we put together because we think the time for biologics combinations has come. And you can think of this in many different ways. Shown here on the left are 3 different scenarios of PSA patients. I'm not going to read through them, you can see. And then we envisioned how we might be able to approach this in a combination methodology, which could be, you know, induction, with induction using lower doses, or spanning out the way it's given. You can look at induction maintenance, and you can look at a domain approach where you start treating the most severe domain, and if that responds, but let's say you start with the skin and the joints are still active, you might then come in with another agent in combination. So there's very many approaches, and we're now talking about this, but I do think that combination is going to be something we're going to be looking at in the future for all the reasons that I stated at the beginning of this talk. Next slide. So in summary, I've tried to provide some potential solutions for you to improve what I would see as our sort of depressing treatment responses over the decades. And they include this new subset that looks to be very important in driving the immunopathogenesis of this disease and trying to find ways to alter the cell population without having a major impact on host defense is going to be, I think, an area we're going to be focusing on. Weight reduction strategies, I think, are viable but challenging, and maybe intermittent fasting might be a way to approach this in some patients. And then we're going to finally understand whether or not preclinical intervention in psoriasis patients may actually be impactful for the development of PSA. And then lastly, head-to-head trials have provided insights into the IL-17 and TNFs and how their efficacy for various domains. And I do think that combination biologics will be tested in the very near future in this disease. Next slide. These are the folks in my division that I do research with, very gifted group of people, both in my division and in the Center for Musculoskeletal Research. And these are my for research support. And I'm sorry about all the glitches, but I hope that you found this presentation helpful. Thank you for your attention.
Thank you,
Great.
Dr. Ritchlin.
Thank you. Go ahead, Vivian.
I just had a quick question. Are there any autoantibodies found in patients with psoriatic arthritis that are novel that you could talk about?
So Vivian, you've made the leap. I'm glad you asked the question. I had the slide in there, I took it out. So obviously what comes from the data I showed you at the beginning of this talk is that psoriatic arthritis and psoriasis are likely to be autoimmune diseases. We just don't know the antigen. So there was a paper in ANR January 2020 where they looked at I'm trying to think here, both ADAM5-ST antibodies and LL37 antibodies and PSA, and showed they were quite elevated. Now, obviously, that's not specific in terms of the LL37 because these have been shown to be present in both lupus and in psoriasis, but they were certainly quite elevated in PSA as well. So that's a possibility. And then the ADAM5-ST, they were elevated as well. My own bias, and this is totally a bias, and I don't know if it's true, is that there may be multiple autoantigens that drive psoriasis and psoriatic arthritis, and that we're now going to be embarking on a journey to try and find those. I just reviewed a grant yesterday for the National Psoriasis Foundation from a group in Australia that has a beautiful protocol to use libraries that they've developed of antigens in psoriasis to screen those and determine if there's antibodies. So you're going to see a lot of emphasis on this now, Vivian, but right now I can't say that we have one identified.
Thank you. Thank you, Dr. Ritchlin.
Thank you, Dr. Ritchlin. That was fantastic. And I think, we can get everybody a pass on the Zoom for at least one more year.
Okay, no problem.
Quick question.
I wouldn't be somebody
sorry, David, it's Gabby. I just had a quick question. Any markers that you can follow for disease progression other than radiographic or because the CRP and the SR often can be normal in this setting?
Gabby, great question. We're working very hard to get those markers. We don't have them right now. I mean, there's a number of those that we are looking at. I have an R01 that's looking at something called DC stamp, which is a molecule that drives cell-cell fusion in osteoclasts, and it appears to be maybe a marker of activity. And we've just completed all the studies and now analyzing the data. CCL10 has been presented as a possible biomarker by Daphne Gladman's group. And of course, now there's a whole bunch of emphasis on metabolomics and proteomic biomarkers. And there's some really important potential candidates that we've identified and others. But I think it's going to take at least another year or two for us to be able to at least have some candidate markers we can test in larger populations. For the clinician today, it's your judgment, and that's the best thing so far, unfortunately.
Thank you.
Great. Dr. Ritchlin, I wouldn't be a true endocrinologist without asking a question about energy balance and weight and that paper from Cell that you showed. I'd be remiss if I didn't bring it up. So obviously there's lots of factors that go into this. You showed improvement in beta cell function with improvement in insulin and C-peptide. You showed improvement in GLP-1 levels, although not to the same degree as insulin and C-peptide. So there's lots of factors at play, but wondering if there's anybody that's looked at, or if you have any thoughts on the different factors, whether this is just negative energy balance, whether this is improvement in hyperglycemia, if it's improvement in insulin resistance, or if it's just weight loss alone that's doing this.
Oh no, I think it's the former. There's a lot of work been done, as you know, looking at the overlap between metabolic pathways and immune pathways, and the crosstalk that's going on. And I think that that crosstalk occurs not only at the level of the receptor, but also at the level of the organelles, also at the level of the transcriptome. And there's a lot of this that is very much integrated. That's a very commonly used term. I apologize, but it's true. And I think that there are multiple effects. It's not just the weight loss. It's absolutely the effects they have on both the metabolic pathways and the immune pathways and where they coalesce. That's my own, again, hypothesis, but I think others feel the same way. There's a lot of work. I just reviewed grants for National Psoriasis Foundation yesterday. There's a lot of work going on in this area. It's very, very hot topic, and very fine labs are really delving into this finally, and I think it's well overdue.
Yeah, it'd be interesting. There's lots of ways that you could look at each one of those factors independent of others. There's medications that reduce weight that don't change hyperglycemia, insulin resistance as much as others. You could reduce glucose without improving insulin resistance. So there's different ways you could tease it out. So very interesting.
Yeah, well, we know with all the new medications for diabetes and the organ effects that they're having, which are fascinating. We're only beginning to understand that we're going to see similar kinds of things in our diseases as well, I think.
Very exciting.
Agreed.
Wonderful. Well, we're a couple minutes after the hour. I don't know if anybody has any last questions or comments you want to put in the chat. Otherwise, we can close for today. Thank you very much, Dr. Ritchlin, for your wonderful talk. And I posted the CME code in the chat. And next week, we're going to have Dr. Armstrong from MGH with our annual Dr. Robert Pinel's lecture on humanism in medicine. So thank you all for attending today. And thank you, Dr. Ritchlin.
Yeah, give my best to Naomi and tell her she had a great wedding, okay?
Thank you. Thank you, Dr. Richland. Bye-bye.
Okay. Bye.